The topic for this presentation is thyroid eye disease. We'll be discussing introduction, clinical features, and investigation. In the next lecture, we'll be discussing treatment. Starting with introduction. Thyroid eye disease, also known as thyroid-associated orbitopathy and Graves' ophthalmopathy, is a very common orbital disorder and is the most common cause of both bilateral and unilateral proptosis in adults. Thyrotoxicosis or hyperthyroidism is a condition involving excessive secretion of thyroid hormones. Graves' disease, the most common form of hyperthyroidism, is an autoimmune disorder in which IgG antibodies bind to thyroid stimulating hormones receptors in the thyroid gland and stimulate secretion of thyroid hormones. It is more common in females and may be associated with other autoimmune disorders. Presentation is often in the 4th or 5th decades with symptoms including weight loss despite good appetite, increased bowel frequency, sweating, heat intolerance, nervousness, irritability, palpitations, weakness, and fatigue. There may be enlargement of thyroid as it is shown in the figure, tremor, palmar erythema, and warm and sweaty skin. Thyroid acropathy or acropathy is a phenomena similar to clubbing of fingers, as it is shown in the second figure, which occurs in about 1% of population. Pretibial myxedema occurs in 1 to 5% and is indurated thickening of the skin of shins. Cardiac manifestations may include sinus tachycardia and other arrhythmias. Other autoimmune disorders can be associated. Thyroid functions are commonly tested initially with a TSH level. If this is low or normal but thyroid disease is still suspected, a range of additional investigations can be carried out. Treatment options include carbimazole, propylthiouracil, propranolol, thyroid ablation with radioactive iodine, and partial thyroidectomy. So, risk factors for ophthalmopathy. Once a patient is diagnosed with Graves' disease, the major clinical factor for developing thyroid eye disease is smoking. The greater the number of cigarettes smoked per day, the greater the risk, and giving up smoking seems to reduce the risk. Number 2, women are 5 times more likely to be affected by thyroid eye disease than men, but this largely reflects the increased incidence of Graves' disease in women. Number 3 is radioactive iodine to treat hyperthyroidism, and it can worsen thyroid eye disease. The condition can also, though less commonly, occur in euthyroid and hypothyroid, including treated hyperthyroid patients. It can sometimes be presenting manifestation of thyroid-related disease. Pathogenesis of thyroid ophthalmopathy involves an organ-specific autoimmune reaction in which an antibody that reacts against thyroid gland cells and orbital fibroblasts leads to inflammation of extraocular muscles, interstitial tissues, orbital fat, and lacrimal glands, characterized by pleomorphic cellular infiltration associated with increased secretion of glycosamine glycans and osmotic imbibition of water. This is an increase in the volume of the orbital contents, particularly the muscles, which can swell to 8 times their normal size. There may be a secondary elevation of intraorbital pressure and the optic nerve may be compressed. Subsequent degeneration of muscle fibers eventually lead to fibrosis, which exerts a tethering effect on the involved muscle, resulting in restrictive myopathy and diplopia. Starting with the clinical features, thyroid eye disease typically proceeds through a congestive, which is the inflammatory stage, in which the eyes are red and painful. This tends to remit within 1 to 3 years, and only about 10% of patients develop serious long-term ocular problems. Then a fibrotic or puissant stage follows, in which the eyes are white, although a painless motility defect may be present. Clinical features broadly can be categorized into soft tissue involvement, lid retraction, proptosis, optic neuropathy, and restrictive myopathy. A commonly used classification for severity of thyroid eye disease has been issued by the European Group on Graves' orbitopathy or UGOGO, which is number one, sight threatening due to optic neuropathy or corneal breakdown, moderate to severe with one of moderate to severe soft tissue involvement, lid retraction of 2 millimeters or more, diplopia and proptosis of 3 millimeter or more. Number three is mild with a minor impact on daily life. So we'll start with first clinical picture, which is soft tissue involvement. Symptoms are grittiness, red eyes, lacrimation, photophobia, puffy lids, and retrobulbar discomfort. Signs include first is epibulbar hyperemia. This is a sensitive sign of inflammatory activity. Intense focal hyperemia may outline the insertions of horizontal recti, and it can be very clearly seen in the figure. You can see the hyperemia along the line of either medial or lateral rectus here. Then there is periorbital swelling, which is caused by edema and infiltration behind the orbital septum. This may be associated with chemosis and prolapse of retroseptal fat into the orbital septum, into the eyelids, which can be seen here. Retroorbital fat seems to have prolapsed into the eyelids, and you can see it here as well. Tear insufficiency and instability is common. Corneal signs are exacerbated by lid retraction and can include punctate epithelial erosion, superior limbic keratoconjunctivitis, and occasionally bacterial keratitis, thinning, and scarring. Then comes lid retraction. Retraction of upper and lower lid occurs in about 50% of patients with Graves' disease. Overaction of Muller's muscle is postulated to occur as a result of sympathetic overstimulation secondary to high levels of thyroid hormones. Fibrotic contracture of the levator palpebrae and inferior rectus muscle associated with adhesion to overlying orbital tissue is another probable mechanism, together with secondary overaction in response to hypo or hypertropia produced by fibrosis. Now, symptoms are patients may complain of a staring or a bulging eyed appearance, difficulty closing the eyes, and ocular surface symptoms. Signs include the upper lid margin normally rests 2 millimeter below the limbus, as it is shown in the figure in the right eye. Now this is the normal presentation, but this is not happening in this eye. Lid retraction is suspected when the margin is either level with or above the superior limbus, allowing sclera to be visible. The lower eyelid margin normally rests at the inferior limbus. Retraction is suspected when sclera shows below the limbus. Lid retraction may occur in isolation or in association with proptosis, which exaggerates its severity. The Dalrymple sign is lid retraction in the primary gaze, and it is seen here. You can see the retracted lid in the primary gaze, and this is Dalrymple sign. Then is the Cocker sign, which describes a staring and frightening appearance of eyes, which is particularly marked on attentive fixation. It can be seen in this figure, explaining the Cocker sign. And then in the end is the von Graffi sign, signifying retarded descent of the upper lid on down gaze. we can see that more prominently in the right eye. So moving, then we are discussing proptosis, where symptoms are similar to those of retraction, of course. Signs, proptosis is usually axial, unilateral, or bilateral, symmetrical, as it is shown in the first figure, but it can be asymmetrical as well, as it is shown here. It is asymmetrical, and it is frequently permanent. Severe proptosis may comprise lid closure, and along with retraction and tear dysfunction can lead to exposure keratopathy, corneal ulceration, and infection. Then comes restrictive myopathy. Between 30% and 50% of patients with thyroid eye disease develop an ophthalmoplegia, and this may be permanent. Ocular motility is restricted initially by inflammatory edema and later by fibrosis. Symptoms include double vision and often discomfort in some positions of gaze. Signs in approximate order of frequency are: number 1, elevation defect, which is caused by fibrotic contracture of the inferior rectus. Then is the abduction defect due to fibrosis of the medial rectus, which may simulate sixth nerve palsy. Depression defect secondary to fibrosis of superior rectus. Adduction defect caused by fibrosis of lateral rectus. So first muscle that is affected is the inferior rectus, and then is the medial rectus, then is the superior rectus, and then is the lateral rectus. You can make any mnemonic with that order. The mnemonic that I go with is I am super lazy. It helps a lot. Now, going forwards, the next is optic neuropathy. It is fairly common in up to 6%, and serious complications caused by compression of optic nerve or its blood supply at the orbital apex by the congested and enlarged recti and swollen orbital tissue. Such compression, which may occur in the absence of significant proptosis, may lead to severe visual impairment if adequate and timely treatment is not instituted. Symptoms include impairment of central vision, which occurs in conjunction with other symptoms of thyroid eye disease. In order to detect early involvement, patients should be advised to monitor their own visual functions by alternately occluding each eye, reading small print, and assessing the intensity of colors, for example, on TV screening. Uh, Signs include a high index of suspicion first should be maintained for optic neuropathy, and it is important not to mistakenly attribute disappropriate visual loss to minor disease. Visual acuity is usually reduced but not invariably. Color desaturation is a sensitive feature. There may be diminished light brightness appreciation. RAPD, which is relative afferent pupillary defect, if present, should give cause for marked concern. Visual field defects can be central or paracentral and may be combined with nerve fiber bundle defects. These findings, in concert with elevated IOP, may be confused with primary open-angle glaucoma. The optic disc may be normal, swollen, or rarely atrophic. Now, in the end, investigations where the blood test for thyroid disease they are not necessary if the diagnosis is evident clinically, but the exclusion of other conditions is sometimes indicated. Visual field testing is carried out if there is suspicion of optic nerve compromise and may be performed as a part of baseline evaluation, even if there is no apparent visual impairment. MRI, CT, and ultrasonographic imaging of the orbits are indicated in some circumstances, such as helping to confirm an equivocal diagnosis by identification of typical pattern of extraocular muscle involvement in thyroid eye disease, consisting of muscle belly enlargement with tendon sparing. Imaging is also used in the assessment of optic nerve compression and prior to orbital wall surgery. Visual evoked potentials are sometimes utilized in optic neuropathy. So we are concluding this lecture here. If you like the lecture, please press on the like button and subscribe to the channel. Thank you all.